in this awesome talk. Thank you, Gaurav, for that intro. So I'm excited now to present the second part of this talk on stem cells. We did a pretty thorough look over last time into a lot of the details to be able to better understand the literature that pertains to stem cell treatment. I'm going to briefly go over some of the main points from last time, just for anybody that wasn't there. And the goal today was really to have this one look more like a journal club. So I chose four articles, three studies that we're going to look at really from a methodological assessment standpoint, look at where some of the strengths and mostly the limitations are in the literature right now. And then I'm going to conclude off an interesting review that I found to hopefully give you guys a nice take-home message. So nothing to disclose for today's talk. As we said, so today's really going to look like a journal club. I have a systematic approach and outline for these types of presentations. So you're going to see that we're going to go over a nice intro, the methodology, results, and then I'm going to try and give you my 2 cents for any of these articles. When I do these kinds of talks, what I find particularly interesting are people with more experience and who do more research than me. If there's anything that you guys see with respect to these articles that I don't see from a statistics or research standpoint, I know it's not as easy to have it interactive via Zoom, but we're definitely open to anything that you guys want to add. So we're going to get started. The objectives for today were really to review it. Last time we went over a whole lot of definitions. We explained what the sources of stem cells are in MSK therapy. We briefly touched on how we think these might work, and that unfortunately putting these stem cells into a knee and having them miraculously turn into cartilage cells is maybe not as realistic as once we postulated, and that there's maybe other ways that we're getting there. We looked at how we harvest these cells, some of the adverse events. We took a long time, or at least to understand where we are today. So hopefully now we can attack these articles with a better background. So a quick overview, mesenchymal stem cells are the ones that we're most interested in. These are the ones that are being researched for most MSK pathologies, so joint diseases, tendon diseases. Mesenchymal stem cells come from the mesoderm, which is one of the 3 germ layers in the early embryo, and that will eventually differentiate into a whole bunch of different cells, such as bone, cartilage, muscle, the bone marrow, and tendons and ligaments. We have an international society that tries to govern what we do with cell therapy and stem cell therapy. So there's very strict criteria for what we can call an MSC, a mesenchymal stem cell. So there's in vitro and biological kind of check marks that we need to get to be able to call it that. And they are referred to as multipotent stem cells. We discussed last time that there's 2 main sources studied right now and where we can harvest these cells. So either from the adipose tissue, usually it's in the belly, or in the bone marrow, usually in the iliac crest. We have more experience with the bone marrow harvest just because we took it from our hematologists and we have more experience with it. But more recently, adipose tissue has gained more interest and is being more and more studied. I had developed this table for you guys last time to kind of compare and contrast the 2 main sources. So the bone marrow stem cells and the adipose cells, the 2 main sites of harvest. Maybe if we take the last row here at the bottom, the different types, whether they're cultured or non-cultured, or whether we manipulate them a lot, whether we play at them, whether we want to expand them or not. This is what brings in the term of minimally manipulated or not minimally manipulated, which was a big definition to try and understand where stem cells fall within legislation in Canada, whether they're referred to as a cell and a tissue, or whether they're referred to as a drug. And so this is what can be a little bit dicey and change between different countries and governing bodies. But depending on how much you play with these cells, once you harvest them, will make that it's either considered minimally or not minimally manipulated. So I'd mentioned the mechanism. So I had this very schematic and idealistic picture last time where I had this knee with a whole bunch of potholes in it and cartilage defects, and we inject these beautiful MSCs, and then suddenly we have a nice new knee with new cartilage. And then unfortunately, we're having a hard time in the literature to prove this correlation between clinical benefits and the radiological expectations that we would see. So where these big cartilage defects don't always get grown in. So this, either through MRIs or through second look arthroscopy, we're having a hard time showing this consistently. So it's only in the last couple of years that they've come out with the hypothesis of another mechanism of action, which is via this secretome. So the fact that these cells can secrete a whole bunch of biological substances, growth factors, antifibrotic, anti-inflammatory substances, and maybe these are the ones that are actually causing some of the clinical and functional benefits we do see in some patients. So just to keep in mind. Gaurav and I decided to really focus on knee-OA and stem cells in knee-OA, as it's by far the most studied pathology for MSCs. As you can see on the table on the right here, most of the main joints where either you get osteoarthritic changes, osteonecrosis, or big chondral defects, let's say in the post-traumatic athlete population, have also been studied. The spine world has also taken interest into this, so most notably intradiscal stem cells. I hesitated for a moment, maybe going off on topic and talking about that, but as you'll see today, if the literature for knee OA is poor at best, for the spine world, well, it's even less. So we're far from being able to support it in the spine world, definitely. One of the probably most important take-home messages last time was this very, very busy slide. There was a consensus statement in 2017 where a bunch of people came together and they kind of looked at the literature and they looked at a lot of the limitations in the literature and the fact that different people are publishing in different ways with different protocols, and this lack of homogeneity made that we were unable to extract big conclusions across the board. So these are the MIBO, M-I-B-O criteria. It was about 60 to 64 criteria where in an ideal world, researchers would describe at least all of these steps in their study so that we can reproduce it and analyze it properly. And we're going to talk about this today. So for each of the 3 articles, I gave them my MIBO score. I tried to calculate it as much as I could. This was their results. So this is a heat map of all the different studies that looked at how well or how poor they are reporting. And all the red spots are basically all the missing data to be able to analyze all the studies. And the average kind of reporting was only about 51% across the board. So we weren't that good at reporting on all the details that we needed to properly assess things. So with that in mind, we're going to jump to the first article. So this is 2 articles that I chose for one study. It was published in Spain. The first article came out in 2016 and the second one in 2018. It was a randomized controlled trial with ethical review board approval and no obvious conflicts of interest. And the 3 articles I chose, I tried to get ones that highlighted different sub-aspects of MSC therapy. So the first one, as you'll see here today, is one that's looking at different doses. The second article is going to be using adipose tissue, adipose stem cells instead of bone marrow. And the third one is looking at allogenic stem cells instead of autologous. So each one was to kind of try and look at different aspects of it. So for this one, by the group with Lamo Espinoza and colleagues in Spain, looked at 2 different doses of stem cells. So it was a 3-group RCT where the control was hyaluronic acid. They recruited a total of 32 patients. So we were about 10 per group, where they gave the two interventional groups were a low dose of MSC and a high dose of MSC, so 10 million and 100 million cells respectively. And unfortunately, it was a little ambiguous early on in this article to determine whether things were blinded. They didn't mention it overtly, and it was only in one of the last lines in the discussion and conclusion that they kind of admitted that for ethical reasons, they couldn't blind any of the patients or the assessors. So despite that this study is frequently reported and recited in the literature, right off the bat, we start with a pretty big deficit in the lack of blinding for patients, interventionalists, and assessors. That being that, we're still going to look at the rest of the article. The preliminary study in 2016 followed patients up at 3, 6, and 12 months, and then they were good enough to follow patients up until 4 years, at least on a clinical standpoint. So the inclusion and exclusion criteria, we're going to look at them for this study, but they're going to look pretty similar for the next 2. They're pretty standard exclusion criteria for a lot of the comorbidities. As you'll see, cortisone and NSAIDs were also standard exclusion criteria. As we mentioned last time in the talk, these 2 medications can have a cytotoxic effect, at least in vitro, on mesenchymal stem cells. So this is commonly reported in these studies. Classic kind of over 50-year-old patients with knee-OA. I'm going to kind of attention to the use of the Kelgan scale, which I have a picture of it in a second. They use this in all studies to recruit usually a minimal of grade 2 AL stage. So it's a radiological score of the severity, at least on X-ray, of knee OA. So they use this and they take nobody that's a grade 1 or less. You have to at least have grade 2 or higher. And the problem with this, or at least to me, is that the clinical correlation of the Kellgren-Lawrence scale is not great at best. It's something that's used more in studies, but we see commonly in people who do MSK practice, and I see a lot of these degenerative knees where you can have people who are grade 4 and have minimal pain, and you can have people that are grade 1 or even less and who have significant pain as well. So by limiting ourselves to the KL grades of 2 or more, we might be automatically taking patients or maybe potential good patients on the lower end of the spectrum who still don't have that much degeneration, but that could potentially be good candidates for therapy. So to keep in mind, most of the studies look at this as an inclusion criteria. So they randomize their patients into 3 groups: the control group, the low dose group, and the high dose group. I always take a good amount of time to look at the famous table 1 to see for any possible confounders. I was a little disappointed because it was a very limited table 1 where they didn't give us a whole lot of data. One thing that does jump out is in the low dose group, you can see that they were heavily weighted in the KL grade 4. It was not statistically significant, but if we just look at it, there's still 70% of people that ended up with at least radiologically severe OA. So I'm going to explain the outcome measures that they use, and then I added to this table 1 in a few slides just to kind of have a better comparison of the baseline data between all these patients. Outcomes are pretty classic through all of these studies. So the VAS, the Womac are the 2 that you're going to see most commonly. I'm going to introduce the Womac scale in a second for people who might not be as used to it. And they use the MRI imaging to follow up these patients radiologically to see if we are getting any of these postulated differentiation mechanisms. One of the things that I emphasized a lot in the first talk was the do no harm concept in chronic pain. And ideally, I would like these cells one day to revolutionize what we do to these degenerative joints, but we want to make sure that we're not doing any harm. And there have been some catastrophic stories in other countries in areas where it's less regulated. I did present a review last time, which did give evidence to at least a pretty good safety profile. And I'm going to highlight now that all 3 studies that I'm presenting today did not report any serious adverse events. So this was something that was nicely reassuring and just adds to the building body of evidence that at least it doesn't seem to be doing any harm in the short to medium term. So the Womac scale, for people who are less familiar with it, is a functional outcome measure used for hip and knee OA. There's 3 big domains: pain, stiffness, and physical function, where patients will fill it out on their own in a Likert scale fashion. The total score is then put onto 98, where higher scores are worse. We do have validity data to show us, or at least to be able to determine what a Womac responder is. So someone who has a 20% overall improvement in at least 2 of these domains and with 10 points overall can be considered a clinical responder. So kind of in the same realm as our MCID or the minimally clinically significant differences. So we'll keep that in mind when we look at the results in a few seconds. For most of the imaging studies, this is how they're going to set their patients up to follow up X-rays. I'm not going to talk about it too much more because I think if there's anything that we should follow, it is the MRI data. The X-ray follow-up is pretty rudimentary, and we can really question the clinical correlation of it. For the MRI, so all 3 studies that I'm going to present today will follow up patients with MRIs. Again, this kind of just goes to the problem that I pointed out earlier, that there's this lack of standardization. In this study, they use this Worms score. In the second one, they use the Noyes, N-O-Y-E-S. And in the third study, they have another score that they use to assess cartilage health, if you want. So for this one, we're going to look at this one here and see what the trend is over this time span. So I took the outcome measures and the baseline characteristics through all of these data that we're going to follow through the first year and then the 4 years after that. And I added them kind of to the table 1. So I'm in no way able to do stats and calculate p-values for you guys, but I wanted to at least see how comparable these 3 groups were in terms of baseline pain, baseline Womac. So in terms of the VAS score, they're relatively comparable. One of the things for the Womac scale that I want to point out is that these are patients that are on the lower end of the spectrum in the 30 to 35 mark. This is a scale that goes all the way up to 96. You'll see in the next study that patients are more in the 50 to 60 range. So already there we have patients that are on the lower end. So you could maybe hypothesize a floor effect, unable to being determine a very significant change in these patients. So with that, we're going to jump into just quickly for the statistics. So they had calculated based on standard alpha and beta that they needed 10 patients per group, which they managed to get. Most data in this study was presented as medians with an interquartile range, and they clearly stated that they were going to perform an intention to treat analysis. So this is the score that I was telling you earlier. So how good were they at reporting all the details that we need if we wanted to redo this exact study? So this is one of the ones that was done before the MEBO criteria came out. So they were only at 51% reporting. So very on average, not great, difficult to reproduce. This is the other thing that kind of, I felt like if you're going to go out of your way and put all this time and energy into an RCT, their injections were done under landmark guidance, which is done, I know, clinically very commonly. The range of confirmed intra-articular injection varies a lot depending on experience and where it's done. And I found this one review that the range, depending on where it's done, can be as poor as 56% intra-articularly. We hope that these guys were, at least 100% intra-articular if you're going to be putting these beautiful MSCs in their knee. But that was another thing that was kind of a little disappointing to read in this study. So for results, we're going to start by looking at the VAS in the control group, the low dose group, and the high dose group. So you can see what the median scores and the trend were over 3, 6, and 12 months. So in the control group, we get minimal of that, whereas in the low and high dose group, we get a relatively nice trend towards improvement where the baseline starting value of 7 ends up being at 2, and then 6 also down to 2. The stars are their statistical significance, which were found for both the low dose group and the high dose group, but only when they compared to the initial standpoint of that same group. So for this first follow-up period, there was no between group statistical significance calculated. And I went to check in the supplementary annex, and I couldn't find that information either. For the Womac score, so I highlighted here the overall result of the Womac score, which was a little surprising when we compare it to the VAS score from just before. If we look right away at the 12 months, we see that our control group here on the left went from 29 down to 13, the low dose group from 37 to 21, and the high dose from 28 down to 16. I'm very visual, so I created my own little rudimentary graph here, which is kind of surprising to see what the trend looks like over 1 year. Our low dose group started off definitely a little bit worse than the other ones, but surprisingly, this control group also did not do that poorly, at least functionally. And these patients were not blinded, so they knew what they were getting. And this does just mean that our hyaluronic acid is doing at least its job for a full year. I wasn't able to find I wasn't able to put on this graph the interquartile ranges to see if there was any significant overlap, but it gives you an idea of trend at least over that first year. So this is the MRI score that I was talking to you about. Basically, the higher the score, the worse the cartilage health is. And we can see that in the control group, it gets a little bit worse over that 1 year. In the low dose group, so these were patients that already had a much worse Kellgren-Lawrence score to start off with, but they did get quite a bit worse over that 1 year period. And the high dose group, maybe a tiny little bit better over that 1 year. What's important to mention is that nothing here was calculated as being statistically significant, unfortunately. So that was the first publication that came out in 2016. This group was good enough to follow a good majority of these patients up for 4 years, which is a pretty significant follow-up time period. They did not continue the radiological follow-ups. They were only able to continue the clinical follow-ups, but still, we'll take a look at that. They only lost a few to follow up. A couple of patients needed total knee replacements, and the other 2 they didn't have any data for. So once again, over the 4-year period, no significant serious adverse events were reported. So we're going to jump right into seeing how their VAS score trended over time. So the long-term follow-up was a little more reassuring than the short-term one. We see that the patients in the control group, so that received hyaluronic acid, kind of as we would expect, trended towards continued worsening of their state. Whereas in the low dose group and the high dose group, there were at least statistical and clinically significant changes in VAS. Here they were able to report on between group statistical significance. So they took both the low group and the high dose, and when they compared them to the control groups, the differences at the final endpoint at 4 years was statistically significant at 0.01 and 0.004 respectively. So a little more reassuring maybe than that first year follow-up, and could be a little more, it pleases to the thought process of how we think these things are going to work in the long term. Whereas we know our hyaluronic acid is generally between 6 to 12 months, and we want to think that the stem cells we put in are going to have much more of a long-term effect, and may even take 6, 12, 18 months to do their full effect. So is that what we're seeing? Maybe. And finally, so the Womac, again, a little bit better than what I presented for the first 1 year follow-up. The control patients kind of flatlined over the 4 year period, whereas both the low dose and the high dose group did improve. But what was surprising here, at least statistically, is that the high dose group, when they compared them to the control group, and probably because of big ranges that we have in data, this was a non-significant difference. Although clinically, I would put them in the clinically significant, as they would meet the criteria for a Womac responder. So that was the first study. I have these next 2 slides are standard kind of my little thought process and analysis for all of these studies. I kind of always go through the internal validity, external validity, and then strengths and weaknesses, and then I try and draw a semi-intelligent conclusion. So first, for the biases, I think the most important thing here is that we're dealing with interventionalists, assessors, and patients who were not blinded. So this is probably the biggest weakness in this study. They were very good at minimizing loss to follow-up. I was a little disappointed in the table 1. So in terms of assessing confounding factors, it was not very exhaustive. And although nothing was statistically significant, the Kellgren-Lawrence scale kind of did trend to a worse, at least radiological group in the low dose patients. And for assessment of random error, well, they stated and reported on basic alpha and beta error. The generalizability or external validity is it's going to be the same thing with all of these studies, and it's kind of the flaw and strength of RCTs, where we have to be quite restrictive in terms of inclusion and exclusion criteria, which makes that sometimes extrapolating this to the general population is a little too difficult. And I'm going to reiterate my one thought of the use of the Kellgren-Lawrence scale as maybe being a little too severe and not as inclusive to potentially get some better responders who would be a little bit earlier on the spectrum. So strengths and limitations are most of what I've already mentioned. So they did, and I'm, this is definitely a good thing on them that they use objective and valid outcome measures. The long-term follow-up was quite impressive at 4 years. They managed to do, yes, some of the blinding on follow-up for the imaging studies, but that was it. And unfortunately, there's a pretty big list of limitations in this study, including the fact that it was a landmark guided injection. They were patients that were overall selected on the lower end of the severity scale for the Womac. Yes, there were more severe KLs in the low dose group. Overall, it is still a smaller sample size with only 10 patients per group. And I think this is becoming, at least in the spine literature where I'm a little more familiar with, where they're using more and more categorical data where they take patients and they clump them into, were you a responder or not a responder, or how many patients responded at least 50%. And sometimes this is a little bit easier to interpret, and it's also easier to draw correlations between that and maybe some radiological outcome. And that's also a limitation for all of the next 2 studies that I'm going to present. They were able to find at least some statistical significance, but a lot of it was within group. And you have to ask yourself, was it clinically significant? The VAS scale borderline, the Womac was kind of just above that 10 points overall. And these, this is a study that only reported a total of 50% of MEBO criteria for MSC trials. So overall, I try to see one study at a time. How do I take this and how is it going to change my practice? So I think the short-term follow-up here was a little underwhelming, maybe a little bit more reassuring longer term, but I come back to the point that these patients knew what they were getting. It was a small sample size, so a study like this, unfortunately, would not sway me to use bone marrow MSCs based on this one study itself. So that was for the first study by Lamo Espinoza in 2016 and 2018. They had looked at bone marrow stem cells. And now we're going to transition to looking at a more recent study by Lee in 2019, where they looked at adipose-derived stem cells and see if that could make a difference for knee OA. So now the first one was a little bit longer. I wanted to introduce some of the outcome measures a little bit better. The next two studies we can go through a little bit quicker because most of these RCTs are designed quite similarly with similar and overlapping outcome measures. So this group managed to recruit 24 total patients with knee OA. It was conducted in South Korea after ethical review board approval and no obvious conflicts of interest. The control group here was a true control group, so no hyaluronic acid here. They really only injected NS, and they went directly with a high dose of MSCs with 100 million in the interventional group. The follow-up period here was a little shorter than average, so they only followed them up for the first 6 months with clinical and radiological data, as I will show soon. Inclusion and exclusion criteria, again, quite similar. They also limited to Kellgren-Lawrence scales 2 to 4. I found it a little bit funny because in the original manuscript, the exclusion criteria were nowhere to be found, and I had to go into the supplementary annex to find it. And then finally, it was exclusion criteria like in most of these other studies. Again, highlight that there's no NSAIDs or cortisone prior to these injections. So this group did a better job, at least at giving me a table 1 with better baseline characteristics to be able to compare and contrast the two groups. I'll highlight here that they were patients who at least radiologically were a little less severe, so mostly in the grade 2, grade 3, and there was no obvious difference between groups. And if we compare their Womac score compared to the previous study, these are patients that were in the 60-55 range, so these are considered more moderately severe Womac patients, at least functionally. So similar outcome measures were used, the Womac, the VAS, MRI, and X-ray, and they added here the KOOS or the KOOS, which is the knee osteoarthritis outcome score, which is just another functional outcome measure used in knee OA. So I'll mention it in the results quickly, but something also similar, which is definitely not more valid or does not give more information than the Womac scale for knee OA. So I'll highlight again here, so very reassuring to me, no serious adverse events reported during the follow-up of this trial. Similar statistics, standard alpha and beta used, they had powered it to only need 5 patients per group, but ended up recruiting 12 per side just to have a safety margin for dropout, but there was no significant dropout in this study. They also mentioned intention to treat analysis, and instead of medians here, they reported means with standard deviations. So this was one of the studies that was conducted after the MEBO criteria came out. So I kind of had to go through this paper on my own with that kind of very tedious checklist and see how much of it, they did properly. So definitely well above average. I scored them at about 70%. It was very well described. They used a collagenase, which is an enzyme that basically takes all the adipocytes away from the MSCs in the adipose tissue to allow them to become more free and accessible. And then they took those cells and they put them in a petri dish and they cultured them to expand the total amount. So more than minimally manipulated. They clearly mentioned here that the injection was done under ultrasound guidance. So the injector here was blinded, the patient was blinded, and the assessor for all the outcome measures was blinded. So they did a very good job on the blinding. They called it initially a double blind, but I mean, in theory, they could also fit the criteria for a triple blind. So this is the score for the Womac, and the top left, so in A, we have the total score, B is the pain subscore, C is the stiffness, and D is for function. So again, here they're reporting p-values that are only within group, so pre-post. There's no between group analysis for statistical significance. In all 4 domains, the MSC group did significantly better at the 6-month follow-up. Statistically and even clinically, as I'll show you in a second. If we zoom in on just a general response, so I'd mentioned earlier that a Womac responder is someone who improves by 20% in 2 categories and 10 overall. So with the overall score here, which was quite interesting, the patients went from 60 to 27, so definitely both statistically and clinically significant, whereas the control group kind of flatlined a little bit more. There were no I couldn't find, although they reported that they would give us the standard deviations, I couldn't find them in the annex or anywhere else to be able to see if there was significant overlap. So we have to kind of just take these p-values as given. For the VAS score, also we get clinical and statistical significance over the 6-month follow-up for the MSC group. They averaged from 6.8 down to 3.4, so a 50% improvement at that time spot, whereas the control group also kind of flatlined over those 6 months. Again, no between group statistical significance that was calculated, or were there standard deviations that were given for this data. So the COOS score, which was the other outcome measure, we're not going to go in detail, but they kind of similar kind of outcomes as the Womac, whereas most domains improved from pre-post within the same group, but they did not give us any between group statistical significance. And so again, another one of the unfortunate statistical non-reporting in this study. So radiologically, we talked about the limitations about X-ray, so we're not going to go over that. We're going to look a little bit more at the MRI, where the way that they calculated in this study is basically the software during the MRI scan is able to compute and put together the overall cartilage defect in squared millimeters. So they took this score at baseline at 6 months, and they see what the difference was between the control group and the MSC group. What was interesting here is that they did report on between group significance. The control group deteriorated over time, whereas the MRI group stayed stable. So they didn't improve, but they just didn't get as worse as the control group. And we obtained statistical significance within the MSC group before and after, and at the 6-month timeline between the two groups. So that was interesting. But when we talk about what I mentioned earlier, this clinical radiological correlation, no one is reporting if the patients who are responding clinically are also the ones who are responding radiologically. There are some studies that look at purely the radiological data, but we're having a very hard time putting those two together in the literature. So again, my quick analysis of internal and external validity. So here they use the same objective outcome measures, but definitely a lot better in terms of the triple blind that they were able to maintain for the injector, the patient, and the assessor. There was absolutely no loss to follow-up, and they provided at least a decent table 1 to assess for confounders. They also respected their standard alpha and beta of 5 and 20%. So once again, the extrapolability for the general population remains limited with most RCTs, so we don't need to delve on that for too long. Strengths and limitations for this one. So definitely a few more strengths than the previous study. So definitely very objective, reliable, valid outcome measures. They blinded, good randomization, a true placebo here. The process of harvesting the MSCs was very clearly described with a much higher than average MIBO score. The injection was done at least with some imaging guidance, and the groups were much more comparable at baseline and with a more severe Womac to allow for maybe more difference pre-post. Most of these studies at this point, unfortunately, have the limitation of relatively small sample sizes. We don't have that one landmark study yet in this field where they managed to recruit like 200 patients. So we're going to rely on a lot of meta-analysis where they put all of these smaller studies together to see if we can get a big bulk of patients and a very big N to be able to extrapolate statistics from that. So once again, I think more in this one than the previous study, there was clinical and statistical significance, but there was a lack of reporting of between group, at least for the clinical data. And again, categorical data could have been very interesting here. So, it's always easy to find, flaws in this study, but if I had to put this somewhere on the realm, it was definitely a little more reassuring than the previous study. It reassured me, or at least added to the number of patients with safe use of MSC. There was definitely statistical and clinical significance, maintenance of improvements at 6 months, and radiologically patients didn't deteriorate, but what is this worth if it doesn't correlate clinically? So these are the types of studies that maybe I could start thinking of using this if all of the data was presented at least this way with this kind of evidence. But unfortunately, and as you'll see in the reviews that I present in not too long, this paper is kind of the oddball, and they're not the average. They're definitely above average. So that's the second study. So for the third one here, so this is the final seminal study that I'm going to present. It's a little bit older, but it was the first one to look at allogenic stem cells for knee OA. It was excessively cited in a lot of the more recent papers and reviews. So I wanted to give it a chance and look into it a little bit more. So the premise here is that it can be very time consuming and challenging to harvest autologous MSCs on every single patient that comes to the clinic. You come in and you have to go through that, relatively invasive harvest procedure every single time. Whereas if you have one young, healthy donor patient who is able to provide you with a very significant amount of MSCs and you keep that in your fridge and it keeps growing and gives you enough to treat 4, 5, 6, 7 patients, well then, that makes it that it's cheaper, it's more convenient. The theoretical cons to the allogenic portion is that there could be this possible immune reaction, but kind of above my level of understanding, and I'll keep this to the immunologists, is that in terms of all the different types of stem cells being studied right now, the ones that come from the mesoderm lineage, so the MSC, seem to be immune privileged and immune evasive. And in other patient populations that this has been studied, so lupus, this has been studied in breast cancer and graft versus host disease, we haven't seen the immune reactions anywhere close to what we would expect when we use something that's allogenically derived. So based kind of on this hypothesis, this group of researchers decided to assess allogenic MSCs for knee OA. So a similarly designed study as the other two, they recruited 30 patients with knee OA. This was conducted in Spain a few years ago. The control group here was also hyaluronic acid, so like the first one that I presented. And here they used an intermediate dose of 40 million allogenic MSCs. They followed the patients up at 1, 3, 6, and 12 months. And I had to reread the article a few times to try and understand what this sentence meant. In terms of trying to understand if the patients, the assessors, and the injectors were blinded. This is the only sentence that kind of discussed it, where they said that the patients, radiologists, care providers, and persons assessing the outcomes of the assay were blinded after the assignment. And it was the after the assignment part that I had a very hard time understanding, because it kind of, and in the order of the manuscript, it was put right after they described how the randomization worked. So it kind of seemed like they randomized everybody and then they tried to blind people after. And even if that's not the case, I think it could have been made a lot more evident whether it was blinded or not. So just to keep in mind. Standard inclusion exclusion criteria, so we're not gonna spend too much time on that. The table 1 was kind of my biggest disappointment in this study. So they didn't provide a standard table 1 with a nice comparison between the control group and the interventional group. They presented each patient kind of individually. So patient number 1, what he looked like. Patient number 2, what he looked like, with just basic data in terms of sex, age, what side they injected, which is not too important to me, and what their Kellgren-Lawrence scale was. So I created my own little mini table 1 here on the left, where I averaged out what the age, the KL score, Womac VAS, and how many women versus men were in each group. So at least once I did it, it kind of reassured me that the groups were relatively comparable. There's no statistical analysis done. This is just, on kind of general observation here. So there are patients who are, in the moderate to severe Kellgren-Lawrence scale. They're an average Womac, and the VAS score was maybe a little bit worse in the control, but at least within one entire VAS point. Similar outcome measures were used here, the VAS, the Womac. Instead of the KOOS like before, they found another functional outcome measure, which is the LECAN. And I'm going to just explain that in a second, because it's interesting the way that they did their stats in this one. They also followed patients up with the MRI and the functional quality of life of the short form SF-12. So once again, reassuringly, no adverse events. So even if the fact that it was allogenically injected, there was no immune reactions. The adverse events are like in all of these studies where there's a little bit of pain after the injection, but when they looked at the proportion of patients injected with allogenic stem cells, the proportion of post-procedure pain was exactly the same or very similar to the trials that look at autologous MSC. So at least reassuring on that standpoint. So this is the LECAN functional scale, which is, kind of looks more or less at the same thing than the Womac. They look at pain, some function, some ADLs. It's scored on 24. and the higher a score is worse. So just remember that this is scored from 0 to 24 because what's interesting statistically here, and I think if you go quickly and look at their graphs too quickly, you can get a little bit caught. They powered this study to need 15 patients per group with, again, standard alpha and beta. They didn't mention anywhere if it was an intention to treat or per protocol, but they took all data, and especially something like the Mri scale, which is only 0 to 24, and they put it on a 0 to 100% scale, and then they provided means with standard deviation or standard error. And you're going to see how that can kind of confuse us on some of the graphs. Their MIBO score here was maybe a little bit over average, so they only reported on 56 of the total criteria that they could have. They were able to treat the 30 patients with a total of 3 donor patients, so 3 healthy patients who basically we had extra cells, and so we gave them some fertilizer and made them expand and expand and expand, and we're able to use that to treat the entire realm. So we can definitely see the convenience factor of allogenic stem cells if ever it does kind of give us the clinical results that we do want. The donors were screened for HIV, Hep B, and Hep C. There was no immune matching done though. There was no mention of how the injection was done. They didn't mention on imaging. They just signed that it was done intra-articularly. So we kind of, again, have to assume that it was done blindly like the first study. So for the results, so these are the graphs that they provide in the manuscript. Top left, we have the VAS. On the bottom left here at C, we have the Mri functional scale, and the bottom right is the Womac overall score. So one of the things that you have to watch out for is to look at the scale. So it doesn't start at 0 on the left. For the top left here with the VAS score, it starts at 2.5 and goes all the way to the top. And although they report the little stars that show this statistical significance within group, so not between group, if I look at the kind of brute data, the mean in the MSC group went from like 5.3 down to maybe 3.4. So they're barely at that minimally clinically significant difference of 2 that we look for in VAS scales. And what was kind of funny is in the conclusion of this article, the authors, they mentioned that the pain relief by looking at the VAS was remarkable, being 40%. But when you look at the absolute value, it's a little bit underwhelming. Same thing for the Mri scale. So at the bottom left under the C, the Mri goes from a total score. So remember that this is scores that are being put onto 100. So it's a score of, let's say, 37%, and it dropped down to, maybe let's say 30%. This showed statistical significance within group, not between group. And when I took that score and I converted it back to the original 24-point Mri scale, you barely made a jump in terms of the criteria from, mild, moderate, severe. So clinically, really not that significant to me. And then lastly, for the Womac scale at the bottom right, again, the scale does not start at 0. And our MSC patients went from a Womac score of about 42 down to 37, 38, around there. So just bordering on the clinically significant, but with no intergroup statistical significance conducted. So it's a little bit underwhelming, unfortunately, and I felt like they were trying to present things to make it look good. But when you look at the scales and you bring it back onto its original score value, you can really assess the clinical value of that. So the SF12, which they state in their article is not something that's been shown to be reliable in OA patients, was found to be non-significant between groups. And if it's something that was found to be non-significant for OA groups, then you wonder why it was used in the first place. But still, a quality of life outcome measure that wasn't able to show any difference pre-post or between group in this study. So this is the last way of assessing the cartilage health after these injections. So maybe this is the one that I've heard of a little bit more, and I've seen a little bit more in the literature, is the use of T2 mapping with MRI scans. So to make this, simple, and hopefully people or if there's any radiologists listening, I'm not going to make their ears bleed. This T2 mapping software is able to look at very different points on the cartilage. And depending on the T2 relaxation time, so when a higher relaxation time is a worse score, means more cartilage degradation, loss of cartilage hydration, loss of collagen fibril orientation, that is worse. And this score can go from 0 milliseconds up to 100 milliseconds. So what they did, they took each knee, calculated 88 different points on that knee, and how many of them were over 50 milliseconds, which means pretty bad cartilage. And then they came up with a poor cartilage index. So what the percentage of poor cartilage sites were in the control group versus the interventional group. So here, we see that both groups, the kind of change over 12 months is that they both improved a little bit. There was surprisingly, there was no between group statistical significance, although in the MSC group, the evolution over 1 year was maybe a little bit statistically significant. But if you look at the overall data going down from 14 to 10 is, barely a couple spots in the entire knee that improved from good cartilage to poor cartilage. I wasn't able to find some of the validity data for the use of T2 mapping to see the inter-rater reliability, because it really doesn't seem like it's that much and could very easily be swayed from one to the other over this time course. So really to be taken with a big grain of salt, this radiological outcome that they found. So finally for this one, yes, objective data like all the other ones. The blinding, I'm just not convinced that it was a blinded RCT, or at least it was not clearly mentioned. Again, most of these studies have done a very good job at minimizing loss to follow-up for the selection bias. The confounders, so the table 1 was definitely suboptimally presented, and external validity, kind of like all the other ones that we've mentioned to this point. So few strengths, but mostly the limitations in the small number, the lack of blinding. We don't know how the injection was done. It was at most an average MIBO score, no confounders, and there's this, statistical significance within group, no between group, and the clinical significance of that. I think if between all of these 3 studies, this is the one where the clinical significance was at most borderline. So very doubtful in how I interpret that. So which unfortunately, this study adds to the fact that maybe these cells are safe, which is reassuring, but we're having a very hard time finding this clinical significance. So out of the 3 that I've presented today, this is another one that would not make me justify wanting to use MSCs. So only one of the 3 today was enough to maybe make me think of that. So this is what kind of the seminal literature looks like right now for MSCs in knee OA. What I wanted to do to conclude on and to try and give you guys a take-home message was to find one either landmark study or systematic review with a good take-home message. And kind of when I look at a different topic in medicine, that's usually what I rely on. If there's this one big study with 200-300 patients, which we don't have here. And so then if not, then we have to rely on systematic reviews. And this subject also made me realize that I was kind of historically putting systematic reviews on a gold platter, and I thought that they were this gold reference that was infallible and that there was lack of bias. And so I started to look for those and find one that I could present to you guys. So I had found a first one which drew one conclusion, and then rapidly after I found another systematic review, but their conclusion was a little bit different. And then this one was also a little bit different, and then that one, and then this one. And then there was systematic review after systematic review after systematic review. And right there, if a subject needs this many systematic reviews, you have to wonder why they're not drawing these same conclusions that quickly and that consistently. When I PubMeded MSCs and knee OA, since 2015, there have been 35 systematic reviews on the topic, and just since 2020, there have been 8. So really, you have to wonder why we have to kind of relook at this the different ways. So I couldn't find one that would give you guys a good take-home message, but I did find this group of authors who kind of came to the same conclusion as me. They looked at all the systematic reviews and they said, wow, all these systematic reviews are drawing controversial conclusions. So we're going to do a systematic review of the systematic reviews. So this is the one that I'm presenting today. It's a little bit old. It's in 2018, so their review was conducted up until 2017. But I think the take-home message is important, and it wouldn't have changed much had I think they'd done this with systematic reviews up until 2020. So just very quickly on the methodology of how they conducted this systematic review of systematic reviews. They followed the standard PRISMA guidelines, and they used 3 tools that I had never heard of, but that are used to assess the methodological quality of a systematic review, the risk of bias of the systematic review. So right there, I kind of always just assumed that because it was systematic that there wouldn't be any bias, but I was definitely fooled on that one. And then a last tool that evaluated the confidence in the evidence based on these systematic reviews. So they ended up with all their inclusion-exclusion criteria, they ended up choosing 4 systematic reviews that were published until 2017. So when they looked at those from a methodological standpoint, at least that was reassuring. So the way that they were conducting them using this AmStar tool, they gave a total score of 8, 7, and 7, and then 11 for these 4, which according to this tool is considered quite good quality, at least methodologically. But unfortunately, when they use this robust school, which is the risk of bias scale, unfortunately, all of these systematic reviews and even the ones that have been done more recently would probably score quite poorly on the risk of bias. So already the seminal data that we've looked at has a lot of its limitations, and now we're looking at systematic reviews, which unfortunately also have its its deficits and its lack of standardization and quality to it. So we can't draw very good conclusions, unfortunately, at this point. So their conclusion was that the best available evidence with low risk of bias suggests that there's no sufficient high-level evidence to recommend MSCs for knee-OA at this point. There was enough evidence, or at least confidence in the evidence, that there's safety with these injections, but really that the efficacy standpoint was low confidence at best. So unfortunately, in 2020, almost 2021, there's nothing that I would like more to find something new that I could offer to these patients. These are patients with knee-OA are extremely common. It's something that I see very commonly in a PM&R practice. And we have this gap in the treatment algorithm that I presented last time, where we go from PT to cortisone and hyaluronic acid, which that in itself is costly for patients. And then we kind of have nothing, stem cells, PRP, borderline evidence, and then they have to jump to total knee replacement because arthroscopy has limited evidence for it. So I would like nothing more, but at this point, we're still very, very far from being able to use this and prove its clear-cut efficacy. The big problems are things that I mentioned the first time and reiterated a few times today, is that the data that's out there is very poorly standardized. So we're unable to draw good conclusions with systematic reviews and pool all of this data properly. At least I'll say that the safety profile is reassuring, but just because something is safe, if it's not efficient, I'm not going to use it anymore. And maybe the Kellgren-Lawrence scale is excluding some patients who are early on in their disease who might still have good amount of pain. Are they good candidates? Are these patients that we should be targeting early on? It's one hypothesis, but I don't think it's what's going to change the entire outlook of this type of treatment. So I would hope maybe in the future, but for now, I would not use this on myself or on my patients. And I think, that's the take-home message in 2021. Hopefully I'm invited back here in 5 years and data has changed and we have this fantastic new way of harvesting MSCs and that they make knees grow back. But I'll be realistic that we're still far from that right now. So that's what I had to say for part 2 of MSCs for knee-OA. I wanted to thank everybody. Thank you, Gaurav, for your guidance and help with this 2-part series. It was, at least it check-marked off everything that I wanted to get for myself. So the selfish side of me is happy that I was able to learn everything that I needed to learn. And hopefully I was able to transmit at least a little bit of that to everybody in the audience. So thank you.